I would like to thank Tom, Dave, and Stephanie for allowing me to participate in this very comprehensive program on heterotaxy syndrome. The title, Facing Heterotaxy Together, is very appropriate. The collegiality and dedication from the healthcare workers, the families, and patients working together to face the challenges of heterotaxy is both essential and rewarding. In the next 20 minutes, I will share with you changes I have seen evolve over the past many years. The first are changes in the classification of heterotaxy syndrome. This is integral to diagnosis and treatment. Then I will share with you the improvements and outcomes for these patients. I will show you some of the medical and technological advances that have led to this improvement. And last, but most importantly, I will end by showing you examples of some of my wonderful patients with heterotaxy syndrome, whom I have had personally the privilege to be part of their care. I would like to spend just a few moments discussing the evolving changes in classification of heterotaxy. We were blessed at Boston Children's Hospital to have the two most noted pathologists, Richard and Stella von Prague. Richard would always proudly remind us that his wife Stella was Greek. When giving lectures on heterotaxy, he would always say that the word heterotaxy is from the Greek, with heterotaxy meaning other and taxi order or arrangement. As you have seen in the preceding excellent presentations, as we all know from Stella and Richard that have taught us many decades ago, that heterotaxy syndrome involves many organ systems, and most often the heart, with profound implications. However, heterotaxy syndrome may not involve or have minor cardiovascular abnormalities, yet with a high incidence of morbidity and mortality. Stella and Richard, along with other pathologists, discovered that although the cardiac manifestations in heterotaxic individuals show considerable variability, there is a clustering of abnormalities that is associated with splenic involvement. From their autopsy studies, the spleen was almost always affected. The von Pragues hence defined a classification of heterotaxy syndrome based on absence or presence of a spleen. As shown in this slide of asplenia and the following slide on polysplenia, the von Pragues demonstrated that asplenic and polysplenic patients had important associated defects that help define this classification. Bob Anderson, a well-known pathologist in London, noted that the isometric pattern of atrial appendages could also define and classify heterotaxy into right or left atrial isomerism. Bob also delineated that the two types of atrial isomerism were associated with distinct cardiac abnormalities. There has been an ongoing debate on which terminology to be used, asplenia or polysplenia, or right versus left atrial isomerism. Jim appropriately evaluated 114 patients with a heterotaxy syndrome by CT or MRI to evaluate the atrial appendages, bronchopulmonary, and visceral organ involvement. In summary, the classic pattern of classification were breached in 21% of patients. This study, similar to Yim and colleagues, we have also noted exceptions to the rule of absolute categorization of heterotaxy syndrome. Steve Sanders, head of cardiac pathology, and Tal Kiva, chief of cardiology at Boston Children's Hospital, wrote in their accompanying editorial that this study by Yim emphasizes the importance of an individualized approach to diagnosis based on a systematic segment by segment analysis of each part of the cardiovascular system. Now allow me to change gears to the other aspect I've seen evolve over time. That is the improvement in outcomes for these patients. This first manuscript dates back to approximately 25 years ago when Toronto Hospital for Sick Children reported one of the first comprehensive outcome analyses of patients with heterotaxies. The outcomes were in two parts. The first manuscript was on right atrial isomerism. Note on this slide that many had similar findings to those with asplenia. As you can see, reported in 1998 for patients with right atrial isomerism or asplenia, the 5-year survival rate was quite low at 35%, with a most marked drop-off in mortality within the first really year of life. Subsequently, in 2000, Toronto Sick Children's Hospital reported on their outcome experience with left atrial isomerism. Note that the similar anatomic abnormalities as those with polysplenia. In those patients with left atrial isomerism or polysplenia, there was a very high incidence of morbidity and mortality related to gastrointestinal disorders, including biliary atresia and malrotation, severe bronchopulmonary disease, neurological disease, and associated chromosomal abnormalities. For patients with left atrial isomerism, those that had a biventricular repair, their 10-year survival rate was 66%, and those with a single ventricle, the 10-year survival rate was lower at 38%. In patients without significant heart disease, the 10-year survival was still surprisingly at 80%. This was related to mortality related to the other organ systems involved. This improved survival for patients with a biventricular repair has been an impetus for our center to try and attain biventricular repair when possible. Pooja Baca at Boston Children's Hospital evaluated changes in the prognosis of heterotaxy syndrome in 264 patients from 1984 to 2014. The overall mortality was 40.2% at a median follow-up of 10 years. In a multivariate risk factor analysis, factors associated with mortality included pulmonary vein stenosis, moderate to severe AV valve regurgitation, and univentricular hearts. Again, a factor with lower mortality included patients with a biventricular repair. Again, this data has been one of the driving forces to maintain a biventricular circulation when possible. In general, for all errors, the survival was improved from the earlier Toronto experience. As can be seen, the 15-year survival rate was 61%. Yet again, note a marked drop of survival in the early ages, with a second tapering in older patients. However, when subdivided to patients operated before and after 1991, in the graph to the left, there was survival improvement if operated after 1991. Graph C to the right shows that the 30-day mortality was improved over fourth errors. The next few slides are reviews of a more current unpublished outcome data at Boston Children's Hospital from 1980 to 2023. This graph depicts survival for 754 patients born since 1980 and diagnosed with heterotaxy before 2 years of age. The overall 15-year survival rate was somewhat improved at 65%. Again, The hazard of death is highest in the first year, with a more gradual decline after 15 years of age. This graph, however, depicts survival stratified by birth decade. Survival significantly differs amongst decades, primarily due to the high mortality of children born in the 1980s. There is evidence from the high hazard of death in early infancy observed in the 1980s and 1990s is reduced for those children born in 2000 and later. As seen from the graph to the right, the one-year survival rate in 2020 was 89%. Even surgical outcome for heterotaxy infantile patients has improved. From 1981 to 2000, 135 patients were with heterotaxy infantile had a mean follow-up of 5.8 years. The 10-year survival rate operated with infantile before 1991 has improved from 70 to 93% operated after 1991. However, there was an increased mortality in those patients with total anomalous pulmonary venous connections and subsequent pulmonary vein stenosis. The improved survival for heterotaxy patients, however, can be attributed to recognition and treatment as it relates to associated diseases. Improved collaboration and expertise from other caregivers has been instrumental. At our center, we have a terrific heterotaxy team led by Dave Shidlow and nurse practitioner Caitlin O'Connell, who brings together the team of experts in caring for these patients. Improved imaging such as 3D echo, MRI with 3D rendering, computational flow modeling of AV valves, and CT analysis of complex valves with mathematical modeling aids in medical and surgical care. Cardiac intervention procedures such as dilation and stenting for pulmonary stenosis and conduit rehabilitation is instrumental. Electrophysiology interventions include intraoperative mapping, cardiac resynchronization therapy, continue to improve outcomes. And the advanced cardiac therapy team has been invaluable for their medical treatment of heart dysfunction, as many patients with heterotaxy syndrome have associated ventricular dysfunction. As mentioned, the improved outcomes can be attributed to advancements in such arenas as catheter-based interventions. Susan Foster and colleagues reported on the importance of total anomalous pulmonary venous connections and postoperative pulmonary vein stenosis. The survival has increased with catheter-based interventions for the pulmonary veins with dilation or stenting. Dr. Hoganson has already discussed the importance on computational flow modeling analysis for surgical planning for these patients. This slide depicts the alterations of the hepatic and vascular flow depending on how the vessels are surgically connected to the pulmonary arteries. This picture is from a recently published manuscript from the Departments of Surgery and Electrophysiology detailing the use of intraoperative conduction mapping. The wire grid to the left is placed in the heart and maps the conduction system at surgery before going on bypass. The incidence of significant heart block requiring pacemaker intervention has been significantly reduced with this novel intervention. Understanding the complex anatomy of congenital heart disease is essential for surgical planning. These 3D echo images are taken from an infant with complex heterotaxy. The images to the left are taken during diastole and show the placement of the common AV valve well balanced over the right and left ventricle. The slide to the right is during systole and shows the potential pathway from the left ventricle to the aorta. to this patient with double outlet right ventricle. This is 3D modeling, again, helping to comprehend the complex anatomy of heterotaxy syndrome. To the left, the VSD is outlined in green, and you can see the pathway from the potential ALV to the aorta bypassing the pulmonary outflow tract. To the right is total anomalous pulmonary venous connections to the LS3C in this patient. However, it is not just about survival, but quality of life. The following slides are from patients I've cared for either since birth, even in utero. All patients and families gladly gave permission to show the pictures and tell the stories. Ethan has dextrocardia, transposition of the great arteries, subpulmonary stenosis, and a status post biventricular repair. He is on medications for atrial flutter, and at some point will have a catheter ablation. Interestingly, that Ethan also had abdominal malrotation, but has had no surgery. He is now 8 years of age. He loves third grade and loves to roughhouse with his siblings. Grace is a lovely 25-year-old woman who graduated from college. She had double outlet right ventricle, complete AV canal, and severe LV hypoplasia. She had a last procedure and placement of a pacemaker at 5 days of age. She subsequently had a Fontan and has undergone ablation procedures for AV nodal reentry tachycardia. She is well adjusted, has a full-time job, and walks to her work, as shown in the slide to the right. As you can see in this picture to the left, at birth, Layla was born premature, small for gestational age, and jaundiced. She had a Kasai procedure for biliary atresia at birth and had a biventricular repair for transitional AV canal defect in infancy, including placement of a pacemaker for complete heart block. Despite mitral stenosis, in the slide to the right, you can see Layla is a delightful, engaging 14-year-old girl. She loves school and she loves being on the volleyball team. This adorable young man, Matthew, had this picture taken at discharge 1 week following a biventricular repair for double outlet right ventricle, dominant RV complete AV canal, subpulmonary stenosis, and also total anomalous pulmonary venous connections. At discharge 1 week later, he was in normal sinus rhythm and an echo that only showed mild subpulmonary stenosis. The father calls me every several weeks to share with me that Matthew was doing just great. Patrick is a robust 16-year-old who was born with interrupted IVC, membranous VSD, subaortic stenosis, coarctation of the aorta, anomalous pulmonary venous connections. He underwent a successful biventricular repair and subsequent sutureless pulmonary vein repair for stenosis. Despite primary ciliary dysplasia, as you can see from this picture, Patrick stays very physically fit. And last is Maya. She was born with the worst of possible diagnoses. She was born critically ill at 3.1 kilograms. She had surgery at 1 week of age for diaphragmatic hernia and a large procedure for malrotation. Cardiac-wise, she had a single ventricle, total anomalous pulmonary venous connections, and pulmonary atresia. She subsequently had a Fontan and catheter-based interventions for essential pulmonary vein and right pulmonary artery stenosis. Despite all of this, now at 16 years of age, she came to clinic and told me she wanted to be on the track team. Well, she had a normal exercise test. Her peak workload was 82% predicted. Her peak oxygen consumption was 77% predicted. which is phenomenally good for a Fontan patient. She currently loves being on the track team. So this improvement in overall survival and this improvement in quality of life has been made possible by the collaborative efforts and organized approach as together we face the challenges of heterotaxy syndrome.